Today, the session is going to be focusing on dementia. And before we begin the Quality Board, I'm thrilled to introduce and welcome our special guest today, Honorable Natalia Casadova-Basta, Ontario Ministry of Long-Term Care. In June, Natalia was sworn in office as the new Ministry of Long-Term Care, and she's the member of the Provincial Parliament for Mississauga Centre. Since being elected, she has been an ardent advocate for Ontario healthcare patients and their diverse medical needs. She tabled the Bill 121, that improved Dementia Care in Ontario Act, a forward-thinking bill to improve care for dementia and Alzheimer's patients in trained personal support workers. She successfully advocated to reduce the age of breast cancer screening from 50 to 40, and tabled the motion to expand Ontario lung cancer screening programs. In addition to her political pursuits, Minister Kusudova is a registered nurse, having dedicated herself to frontline healthcare. During the early days of the COVID-19, she also committed to do 12-hour shift in the emergency department at the Etobicoke General Hospital. Very inspirational to us nurses. Minister Kusudova is passionate about improving the life of Ontarians and is a fierce advocate to the most vulnerable in our province. She enjoys serving her community of Mississauga Centre and is proud to represent them at the Queen's Park. And with that, I welcome her to do some remarks.
Well, thank you so much, Rahul. Good morning, everyone. And to Tess, thank you for welcoming me to your beautiful home this morning. This isn't my first time here, but first time as minister. So I'm very, very proud that under our government, we were able to accomplish this beautiful, beautiful build in 32 months, which is quite phenomenal. But today I'm here as a nurse, to learn from nurses because, that's the perspective that I want to bring to my role as the Minister of Long-Term Care. And I think, we nurses, we're leaders in all kinds of spaces and places, and we need to own that role, and we need to advocate for our patients. And so when I met Rahul last time I was here, I was in the position of parliamentary assistant to the Minister of Long-Term Care. I was really inspired by the fact that, right here in our beautiful facility, we have these quality care rounds, which gives us an opportunity for nurses to learn from one another. And so I was very inspired, and I said I would love to come back and participate in one of these quality care rounds. The reason why we chose dementia as the topic for today, because I think it's a very timely topic. We know that our residents, about 70% to 75% of our residents in long-term care do live with dementia. And I do think that number is actually underreported, especially for those living in the community. There is still a huge amount of stigma attached to a dementia diagnosis. And we know that we don't have all the appropriate supports that our families and loved ones and people living with dementia rely on. And that's why I tabled my private member's bill in 2022, improving dementia care in Ontario. And the reason for that is when I was door knocking in the 2022 election, in my riding of Mississauga Centre, not too far from here, almost at every door, I heard a story about someone having a loved one, a mom, a dad, brother, or sister, living with dementia. And a survey that the Alzheimer's Society did actually stated that 90% of voters agreed that the government needs to do more to support those living with dementia. And if you follow political polls, usually voters don't agree on anything that close. But when 90% of people are saying we need to do a better job, well, that spoke loud and clear to me. And so that's why I tabled my bill, Improving Dementia Care in Ontario Act. And actually, even today, I will be having an interministerial briefing with Minister Jones and Minister Raymond Cho, our Minister of Seniors and Accessibility, on putting forward a government strategy on dementia. Because up until today, we don't have a full dementia strategy, and we frankly need one. But today, let's talk about dementia in long-term care. So how many of you have been taking care of a resident living with dementia? Everyone, right? And so how many of you have had specialized training when you were in nursing school specific to dementia? So you see, that's exactly the problem. So especially when it comes to working in long-term care, The reality is, and especially when I spoke to some of our PSWs who are our team members and they work so hard and they have so much skills and knowledge, that we actually don't equip our healthcare providers with the appropriate training to be fully prepared to work with patients with dementia. And the result is that retention, especially among our PSWs, we see that 6 months after starting their first job in long-term care, a lot of them quit because they're just ill prepared to work with patients with dementia. So I think we need to do better as a government, and we need to work with different ministries. So I'm working with the Ministry of Colleges and Universities to ensure that our PSW curricula reflect appropriate modules on dementia, but also experiential learning. And what I love about being the Minister of Long-Term Care is when I get to go to the colleges and speak to PSWs and nursing students, and also visit living classrooms. This is a new concept that we have, right? Where we have nursing students working already on the floor, PSW students working in long-term care on the floor, and they're learning with real residents. And I think that makes a difference. And I think that will also help with our retention issues. So I'm really looking forward to hearing what the experts have to say and to learning from you today. And as I develop this dementia strategy as it pertains to long-term care, I welcome all of your feedback. I will pass my cards around. I will certainly have some nursing roundtables on this topic as well as we move forward with our dementia strategy, because I don't know everything. So I need to learn from you. You guys are the experts. You're the ones who are there every single day working hard to support our residents. And our strategy and our policy has to be informed by the voices of nurses, nurse practitioners, PSWs, etc. So I'll pass around my cards. And if you would like to get involved in this dementia strategy, just send me a note and I'll add you to my email list. And then we'll be hosting virtual roundtables around the province to really help us inform the strategy. Thank you again for welcoming me to your beautiful home. I'm so honored and thrilled to be here. I look forward to working with Tets and the entire team on what we can accomplish together and how we can improve the quality of care for our beloved residents living in long-term care. Thank you.
Thank you, Thank you, Honorable Minister. Good morning, everyone. My name is Rahul, and I'm the attending nurse practitioner here at Wellbrook Place, supporting both your East and West Towers. I just want to take a moment to first say thank you to each and every one of you in this room for taking the time to join and support our quality care rounds today. An education initiative that we are very excited and passionate about here at PCH, and one that we look to grow and develop in the months to come. Now, for those that are unable to attend live, these sessions are also recorded and can be accessed through our PCH YouTube channel. Now, for today, Ruben mentioned that we are going to be talking about dementia. Now, dementia is a very broad topic, and there just never seems to be enough time to fully articulate all the unique qualities and details associated with dementia. And I know time is always an issue. There's always some place that we have to go, something that we have to do. But as the famous Muhammad Ali once said, who in fact lived with dementia for over 2 decades, sometimes it's not about counting how much time there is, but instead, it's about making the time that there is count. So how do we talk about a broad topic such as dementia in such a short period of time? We make the time that we have count. Let's get to it. There's 5 main objectives to support today's learning. And my goal is that today we are going to address each and every one of them in order to inform our practice, in order to optimize the level of care for our residents. So number 1, we want to understand the clinical importance for safely managing and caring for residents that are living with dementia within our home. And we're going to delve into some of the numbers, both nationally as well as more provincially to back that claim. Number two, we're going to identify different types of dementias. Dementia is an umbrella term. There's many different, it's a syndrome. There's many different potential causes. So we're going to go through some of the main ones that likely we're to encounter in our home and other homes alike for the residents that we care for. Number three, we're going to talk about some of those responsive behaviors, those behavioral expressions, verbal or physical, that many of the residents express that go beyond those cognitive decline that we see in the typical dementia presentation. So these are those non-cognitive type of symptoms. And the next, just like in all the previous sessions, we're going to review both the pharmacological as well as the non-pharmacological approaches and interventions that we can do as a team and a person-centered approach to help manage residents that live with dementia on a day-to-day basis. And finally, because we're collaborative over here, we always want to outline a pathway for support. And we're going to show you the step-by-step ways that staff, when they see a situation, when they're working with a resident living with dementia, the pathway that they can follow so we can safely manage and escalate the situation to safely manage that resident and avert a hospital transfer. And I'll just kindly ask for anybody that's online to please just mute your microphone for this presentation, and we will have a question and answer period at the end. But before I continue, does anybody have any pressing questions before we move on? Okay, awesome. Give me 1 second while I log this in. Okay. Okay. So I want to invite you all to first join me in a cognitive exercise. So many of you have probably seen these images in previous experiences before, maybe in social settings. But I'm interested to see, what do you see when you look at this picture? So for those online, please feel free to just write into the group chat. For those here live in person, feel free to just shout out your answers. Tell me what you see when you look at this picture. Anyone? Okay. Okay. So I'm saying young lady, I'm saying fancy lady. I'm seeing an older individual. So I'm seeing a variety of answers over here. So since you guys have all indulged me and been so forthcoming in sharing what you see, I feel it's only fair that I share with you what I see. When I look at this image, I focus in that center part and I see, mind you, this is what I see grapes. For some of you, that may be the young lady's hair. For others, that may be the older ladies, I guess, hair as well. I see grapes. Does anyone else see that? Yes, I'm seeing some yeses. Yeses? Okay, let's try one more. What do you see when you see this picture? I see two people looking at each other. Anyone see anything else? A chalice? Okay, so we're seeing a variety of answers. Again, because you guys have been forthcoming, I'm going to share what I see when I look at this image. When I look at this image, I see a salt and pepper shaker in the middle. Sorry, was it chalice somebody said? Okay. So that's very interesting. So when we look at these images, so much like in our world, it's so much like how we see things very differently. It's the same way that we see residents living day to day with dementia. They interpret their world in a very different capacities on a daily basis. For some, they use their previous experiences. For those that have seen these images before, they're maybe relying on what they've done previously. For others like myself, maybe the environmental cues. Perhaps I'm just a little bit hungry. I'm seeing grapes. I'm seeing a salt and pepper shaker. Regardless, our previous experiences and our current environment shape the lens that we see our world. So these unique experiences influence our journey. They're influenced by previous life events, the current environment, and therefore it's important to understand that these differences, and to understand these differences so we can provide a person-centered approach when caring for residents that live with dementia and not dismiss their reality, but instead to meet them where they're at, to understand what they're experiencing. to be able to work with them together collaboratively to improve the quality of care of their day-to-day experiences. Because ultimately, every single person has a unique identity that's shaped by their previous history and is influenced by current events. So I want you to try to look through the rest of this presentation through that broader lens. Okay, so what does the data show? Okay, so in Canada, if we start more macroscopically before we zoom in, nationally in Canada, we have almost 750,000 individuals currently living with dementia. These numbers are adapted from the Alzheimer's Society of Canada, and by 2030, they're estimating that that number will reach close to 1 million. In fact, they're actually estimating that approximately 15 individuals are diagnosed with dementia every hour. So if I do the math, times 24, we're getting just over what that pictogram at the bottom is showing, just over 350 new cases a day. In fact, that number is expected to grow by an astonishing 187% in the next 30 years. So currently in 2024, it's estimated that just under 9% of residents are currently living with dementia. The Honorable Minister was mentioning that perhaps even in the community, because of a lot of stigma and labeling, that number actually may be lower than it's actually maybe underreported right now. So if we zoom in a little bit more and look into Ontario specifically, it's forecasted to have the largest growth of residents living with dementia by 2030. In fact, there's a growing number of individuals that are now being diagnosed with what's called early onset dementia. These are the ones, so typically dementia has historically been diagnosed in residents that are in individuals that are 65 and older, so the seniors population. But now in this younger subset, we're seeing residents that are in their 40s, their 50s, or even early 60s. When we talk about seniors, that number has grown by over 1.1 million in the past 2 decades. So with an aging population, with more earlier diagnosing, it makes sense that we're starting to see a huge increase in the incidence and prevalence of residents living with dementia. In fact, that risk doubles every 5 years between the ages of 64 and 84. Not to get too bogged down, because I know there's a lot of numbers we're kind of sharing today, but currently there's about 67 new individuals that will be diagnosed with dementia this year alone, bringing that total to just over 316,000 in Ontario alone. A lot of these are living in the community, private caregivers, ones that are unpaid. And when we do the math with that, that's over 5.1 million unpaid hours. Sorry, billion. Yes, thank you, billion. Again, it's always good to fact check the math of unpaid care every week for that year. So let's zoom in a little bit further. Let's talk about our home specifically, Wellbrook Place. The Honorable Minister mentioned that the current data shows, and this is from Alzheimer's Society of Canada, that it's estimated between 70 and 75% of residents living in long-term care have a dementia diagnosis. But when we look specifically at our own census, the percentage of residents living with dementia is about 78%. So just a little bit tick above that. But what does that mean? That means that 3 out of every 4 individuals you're interacting with in the RH and the resident home areas are living with dementia. So then it comes back to the question, why are we talking about dementia today? We have an aging population. We're seeing a diverse range of residents being diagnosed and living with dementia, and that number continues to go up, 78% at Wellbrook alone today. So because of this rapid increase in the number of individuals living with dementia, it's clinically important for us to all understand the unique needs and experiences of every individual that lives with dementia in order to provide a person-centered care plan to improve their quality of life. And we're all here today to try to empower all of you to develop that knowledge, develop that critical thinking skills in order to make those judgments to safely care for them, avert the hospital transfers, and ultimately improve their quality of life. Sorry, I just realized I've been flipping the 2 back. Sorry. So we'll go over here to the screen over here. Okay. What exactly is dementia? It's a term that's loosely used. We see it oftentimes. Someone's confused, oh, they must have dementia. Confusion is just one, confusion is a symptom. Dementia is a syndrome. And in fact, it's an umbrella term. So what that means is there are more than 50 diseases out there that can lead to an individual living with dementia. But something that's common between all of those diseases is meeting these four conditions. So all four of these conditions need to be underneath that umbrella. So number one, there needs to be a neurodegenerative disease. Some of the more common ones that we are probably encountering are Alzheimer's disease, for example. So essentially, there needs to be some sort of accelerated loss of structure, function, or even connections in the brain cells in our brain that leads to this decline. Number two, symptoms that they're experiencing. This is a disorder in the brain. So they're going to have issues, they're going to have challenges with thinking and with memory. That cognition is going to start declining. Some of the major areas that you're likely to see are memory, either short-term, long-term memory issues, executive functioning. These are things about planning, shifting focus, language, both comprehension, expressing yourself, attention, inability to maintain attention, impulsivity challenges, visual spatial function. So recognizing something that may have been familiar before, they no longer can do that, an unfamiliar environment. And then eventually, even in more advanced stages of the specific type, they can have motor control deficits as expressed by weakness. So condition number three, you have the neurodegenerative disease, you have cognitive decline. A few of the most important ones that we're likely to encounter in our population because they are the most prevalent. So number one is Alzheimer's disease. So this is obviously the most common form of dementia that many of you have probably encountered. It's literally characterized by damaged brain cells. They have, to not go into too deep into the pathophysiology, but they have this accumulation of beta amyloid plaques and the neurons get all tangled up and so forth. And ultimately the connections can't be made and we see cognitive decline. So some of the early symptoms you're likely to see in somebody who has Alzheimer's disease is memory loss. One of the most easiest one to recognize. Difficulty even finding words, that language issues. They may get disoriented and have poor insight. They are not aware that they're undergoing these changes. Another subtype is vascular dementia, which is very commonly seen too, especially in residents that have previously had a stroke or cerebral vascular accident. So this type of dementia, again, we're seeing deterioration in the brain cells, but the cause of that is from decreased blood flow to a specific area. So if you have decreased blood flow, the symptoms that you're likely to encounter is going to be determined by that area of the brain that has been that received that decreased flow. But some of the common symptoms you'll see, these type of residents typically have a stepwise functional decline. So they're sort of steady at a consistent baseline. And then one day you wake up, you're going in to provide care for them, and you're seeing all of a sudden they are no longer able to speak the way they were yesterday. All of a sudden they're slurring any type of words that they're trying to express. This is that huge drop, and then they stabilize at a new baseline. As well. Then there's something called dementia with Lewy bodies. These are just abnormal proteins that develop in the brain. These residents will have fluctuating cognition, but the hallmark for them, they'll have more Parkinsonian-like symptoms. So kind of that bradykinesia, that slowing of the movements, the rigidity. You go up to them, they feel very stiff and so forth. And they're very prone to falls. And then they just have autonomic dysregulation. They feel constipated, bladder retention, and so forth. So that's another type. The fourth most common type is frontotemporal dementia. These ones affects the frontal and the temporal side of the brain. And essentially, these are the residents that have a lot of fluctuations in their personality. They may be disinhibited, have social withdrawal, language deficits, and a lot of the motor deficits that these residents have tend to be later on. So the point of this slide is not for you to memorize the exhaustive list of all the symptoms and causes of the different types of dementias. But again, if we're looking at that broader lens, we want to understand that every single resident has a unique experience. And one of the factors contributing to their unique experience is the type of underlying dementia that they're currently living with. And then the final one is mixed. It's just mixed features of more than one of these types of dementias. Okay, so how do we differentiate between normal aging and dementia? Because it's very easy to kind of blur the lines between the two. So this comparison chart contrasts nicely some of the commonly seen symptoms that you might encounter in residents, and it was adapted by the Alzheimer's Society of Canada. So obviously, one of the easiest things is a resident forgetting events from a year ago. Honestly, I can't remember what I ate for breakfast last week, let alone a year ago. Do I have dementia? Maybe, but again, if we're trying to go by that 4-step underneath the umbrella criteria, maybe not. But now, if I start forgetting details about more recent events, as in yesterday, we just had a conversation an hour ago, I don't even remember that I had that conversation. Try to think a little bit more. This is not a sign of normal aging. It may be a possible dementia. Becoming lost occasionally, no normal aging, but becoming lost frequently or in areas that should be familiar to you, more signs of dementia. Sometimes struggling to find your words, normal aging, but pausing and ultimately not able to find that word and just using alternative or substitute words, more clinical signs of dementia. Now, what is part of normal aging is these residents should be able to speak clearly and well, have predictable and stable moods, follow and participate in conversations, and perform their activities of daily living. And that's the key point here. Residents living with dementia, what separates them from potential normal aging, transitioning to cognitive decline, and ultimately being diagnosed with dementia is that impairment in their day-to-day activities of daily living. If I have short-term memory concerns, but it's not impacting my day-to-day functioning, it is not dementia. Okay, so this is just a pictogram to show you some of the common symptoms. We've obviously gone into more detail, but just so you can see visually what some of the symptoms associated with dementia are. Obviously, problems in communication, poor judgment, difficulty with tasks, misplacing things, memory concerns, changes in mood and personality, difficulty solving problems, and then becoming more and more increasingly disoriented. So these are some of the common symptoms that we are likely to encounter in residents living with dementia. Okay, so when are we going to see these different symptoms sort of play out in the life trajectory of a resident living with dementia? Well, the Alzheimer's Society, they categorize, in fact, this is now evidence informed. There's 7 stages of dementia. Originally, this research was based on Alzheimer's disease, but we're seeing similar progression in all the other types of dementia. And essentially what this is, if you go around this wheel, there's 7 stages of dementia where you see a resident that shows no signs, completely cognitively intact, but then they progressively, their symptoms develop and worsen. One of the conditions underneath that umbrella that depicts that someone may be undergoing some dementia changes. So these 7 stages are further categorized into 4 areas. You can have pre-dementia, sort of that normal aging, just normal forgetfulness. But once that kind of transcends into more affecting your day-to-day activities, your executive functioning, you're no longer able to plan or organize yourself the way you once were. Now we're sort of getting into those earlier stages of dementia. Still manageable, a lot more independence. But now when we start progressing to stages 5 and 6, we're getting more to that middle stages of dementia. And what's unique about this stage is where we start introducing some of those non-cognitive neuropsychiatric, or what the term that a lot of staff like to use, the responsive behaviors that we start seeing in our residents. You can still see them in earlier stages of dementia, but just know dementia is a cognitive decline. So why would somebody who's losing their ability to plan, to think, to speak, why would all of a sudden they have go through a depressing episode? Why would all of a sudden they become agitated? because the deeper that decline goes, the more that brain deteriorates, the rest of the functions follow. So these are those neuropsychiatric, the behavioral and psychological symptoms of dementia that begin to develop in the later stages. And we're going to talk about in the subsequent slides how to assess them and what we can do to try to support residents living with those symptoms. Okay, so behavioral psychological symptoms of dementia or responsive behavior. So as I just mentioned, these are those non-cognitive symptoms that residents develop. In fact, up to 80% of residents, in fact, more than 80% of residents living in long-term care or any type of congregate setting for that matter, will exhibit at least one behavioral or psychological symptom of dementia per year. So that clinical presentation can vary, depends on obviously the type of dementia that they have. Again, like analogous to that initial example, that thought exercise we did, it's shaped by their previous experiences, influenced by their current events, the social environmental factors, and they respond accordingly. So what are some of these symptoms that we may encounter? Some of these responsive behaviors. So these are those behaviors such as agitation. Maybe a resident is getting a lot more aggressive, verbal escalation, perhaps even physical. Now we're getting into more of those safety concerns, both for the resident, the co-residents, but as well as for the staff and the visitors in the room as well. The mood disorders, perhaps they're going through that depressive episode, as I just mentioned. They're getting more anxious, becoming indifferent completely. The apathetic mindset. They no longer are just basically indifferent to everything that's around them now. Perhaps they delve even deeper and they get into having more episodes of psychosis, hallucinating, having delusions, getting fixated on certain things, having that paranoia. Often we see this as well too. They start engaging in more exploratory behaviors. So they start ambulating around the unit, visiting some of the co-residents' rooms, trying to exit seek from the unit sometimes, having inappropriate sexual expressions sometimes, changes in appetite, or even sleep disturbances. Oftentimes that will manifest as the resident was just awake all night long, couldn't sleep, and disturbed everybody on the floor. So these are some of those responsive behaviors that we're talking about that are not part of the normal development of residents living with dementia, but are anticipated outcomes as the disease progresses. So why is it so important to understand these responsive behaviors specifically? Obviously, we always want to support residents living with dementia, regardless of the symptoms they're facing. But the clinical implications for responsive behaviors, it leads to more rapid decline of that cognition and more physical decline. These residents tend to suffer from worsening mental health outcomes. I mentioned depression, anxiety, low moods. Ultimately, all of these symptoms together decrease and impact their quality of life. It increases caregiver burden. It increases the safety concerns, not only for themselves, but for everybody around them. And unfortunately, it leads to higher mortality and worse outcomes. So it's important to try to address that. So how do we do that? So let's first start with the non-pharmacological approaches. So our wonderful friends, both previous and current occupants of BSO lead in both towers, they've been very gracious and trained a lot of the staff, a lot of us, and run many in-services on the Behavioral Supports Ontario Dementia Observation System, so the BSO DOS. This is a validated, evidence-informed validated observation tool that documents behavioral patterns in residents to try to identify some of the contributing factors that are leading to some of those responsive behaviors that we're seeing. This is a 24/7 monitoring system, and it captures observational data on 8 behavioral categories, but more can be added if there's concerns in other realms. So this is a good tool to start with to try to get a baseline of where a resident, what a current resident is experiencing, so then we can tailor the care plan accordingly to help fit their unique experience. And then when we're trying to care plan for the interventions, let's talk about some of the basic stuff that we can do. Address physical needs. Perhaps the resident is just hungry. They're expressing it by with verbal expressions that day. Perhaps they're throwing things around because they can't find something. They were looking for their water. It wasn't within arm's reach. So it's very important that every behavior has a meaning behind it. The BSO DOS monitoring the wonderful BSO leads, the BSO unit does this exceptionally well. Understanding the lived experience of that resident by monitoring them can help us to identify these contributing factors so we can address them directly, as opposed to just blatantly medicating everybody, which is not a safe approach at all. And I'll get to that in a moment. Just to close off the physical one, maybe they have to be toileted, personal comfort, perhaps sensory needs. A lot of the residents that are living with dementia, especially in our home, are senior residents. Perhaps their hearing devices are not properly fitted. Their corrective lenses were not on that day. Perhaps there's just not adequate lighting for them to navigate, and that's why it's precipitating that fall. Maybe there's so much stimulation and noise around them that it's just too much for them, and they just need a moment to just calm down. We have a green room in the 2D BSU unit that encapsulates that noise reduction very well. It kind of mimics, it's adapted from the Japanese forest bathing, a Japanese cognitive exercise. But essentially, that you surround yourself in this green room surrounded by forests, trees, bushes, things that are calming of nature. And the idea is residents that may be escalating, experiencing anxiety, depression, it helps to calm you down. Then socially, we have perhaps they just need to be individual group activities, making connections with other residents, family visitation, maintaining a routine, explaining to residents the care activities before performing them, and having them join in, providing mental health support. We're talking about those familiar objects. A lot of residents want to see that familiar object. We see outside of the residence room, what we're doing very well here at Wellbrook, we're putting items in their rooms that are recognizable to them to help reorient them. And then other orientation cues in our dining halls, we have large clocks to orient residents to the time of the day. And then the sense of self, having that purposeful activity and that role clarification, what they are expected to do on a day-to-day basis. And then you want to obviously involve the whole interdisciplinary team. Medically, you want to make sure these are not medication side effects that could explain the behaviors you're seeing, any perhaps it's urine, bladder or bowel related issues, ensuring that they're being fed and toileted, medications are being given timely, engaging with behavioral supports, and using your GPA techniques and your de-escalation strategies, such as the stop and go for escalating situations, redirecting attention, and applying in certain situations, the wander guards and wander strips to ensure that we keep residents ambulating in a safe environment, and then engaging them in more programs and activities and exercise and getting PT involved and providing the emotional support, which social work has done very well. And then ultimately, leverage the experience and knowledge of the family caregivers. They were taking care of a lot of these residents for many years. Leverage their experiences, use their knowledge, share this experience, have a person-centered team approach to managing residents living with dementia. Okay, so if those are some of the non-pharm approaches, what are some of the pharmacological approaches? These would never be first line, but they're always something we want to have a conversation about because sometimes we have situations where things can escalate. So we'll break this down into two basic categories. We have the dementia medications. So some residents living with dementia will take some dementia medications. The research is inconclusive on how much mortality benefit they provide, but the evidence does show it does decrease the progression of the symptoms that they're experiencing, specifically in learning and memory modalities. So some of the medications you may see on the units for the earlier stages, the more mild to moderate dementias, the donepezil is a very commonly one. And in the more severe cases, they may take memantine. But those are the medications that you may anticipate the providers prescribing. But the ones that I want to focus in a little bit more on are those responsive behaviors, those acute episodic situations that can quickly escalate and go, and we want to avert those hospital transfers if safe to do so. So the way we do that is first we want to do that thorough assessment. Perhaps there's another cause that's underlying the behavior that the resident is exhibiting. Maybe it's pain, making sure that their pain is well managed. Maybe it's they just need to go to the bathroom. So making sure that those issues are first handled before we move on to more stronger medications. So antipsychotics is a strong program, and I know BSO and the BSO team leads are actively working on this as an antipsychotic reduction program here at Wellbrook, and we're doing that very well. And the whole idea behind that is government initiative led is we want to eliminate the use of using antipsychotics for residents that do not have a formal psychotic diagnosis. So in certain very limited situations, the literature suggests there may be some evidence to use these antipsychotics, but for in very specific behavioral responses. Specifically, it's those very severely agitated or residents that are going through an acute psychosis where they now become a safety concern either for themselves or for those around them. In those instances, you can use an antipsychotic, obviously with an order from a provider after an assessment, in a limited, short experience, just to stabilize the safety of that situation, but it's not used long-term to manage the resident's symptom. Then we have antidepressants. Obviously, this will require more thorough assessment, especially if the resident's experiencing low moods or anxiety. But sedatives, we never use sedatives to manage responsive behaviors for residents living with dementia. That's a big no. I can't emphasize that enough. There's too many safety concerns associated with it, and the outcomes are very poor. It should never be used to manage. A lot of the approaches to managing residents' behavioral and psychological symptoms of dementia should be non-pharmacological. And if we do that BSO DOS monitoring consistently, we can identify a lot of those contributing factors. Okay. So let's say you've done all that. How are we going to escalate to get the support that we need in case we've done all these interventions and we're still having an unsafe situation? So let's start from the beginning. And this is a pretty similar approach that we should be sort of adapting in any type of clinical situation. But essentially, you want to first go to the care plan. We're a nursing team. We work collaboratively. Pull in the information that the PSWs are sharing with you. See what the rec team have noticed when the resident was attending programs. Use all those information to inform the care plan and use those interventions within your scope of practice to safely de-escalate and better manage residents and their symptoms. It's that team approach. I mentioned using the family caregivers, leverage their knowledge and experience working with the resident. And then ultimately, our friends in BSO, we want to leverage their expertise as well, too, and get some recommendations for non-pharmacological approaches. And then if things are really escalating, especially in those acute, specific safety concern situations, we will also want to involve the medical team, obviously to rule out all those alternative causes that may be leading to behaviors, but sometimes the de-escalate a quickly escalating situation. And then this would also lead into hospital specialist referrals. We have geriatricians on site. They come every week, getting that comprehensive, holistic assessment to help seeing the whole picture and understanding the full story of this resident that's living with dementia, so we can address it from all modalities, and potentially even having a psychiatrist involved as well. So I think I've talked long enough, and I know I wanted to apply some of this. Like I said, dementia is a very broad topic. I'm trying to highlight some of the most salient points for you and some of the takeaways we'll review in the next slide. But let's apply some of that knowledge to a case study. So everything over here, this is adapted from a research project from the Trillium Health Partners. All the demographics have been changed, so not there's no privacy or confidentiality issues. But so I quickly review this case, and then I want to hear your feedback of what you learned from this presentation. What comes out to you when we're trying to safely manage residents living with dementia? Okay. So meet Jean Doe. She's a 77-year-old female resident of Wellbrook Place. She's a retired pharmacist, widowed, has 2 sons that live nearby. Her first language is Italian, but she can speak English fluently. She immigrated to Canada when she was 33 years old. Previously lived alone in a bungalow in Mississauga. Was very independent with all of her activities of daily living. Sons were visiting twice weekly, but as her conditions, as her situation started to change, they started visiting more frequently, almost daily. Unfortunately, she was diagnosed with Alzheimer's disease about 2 years ago and is experiencing significant short-term memory and communication issues, especially over the past year. She can still independently eat and walk, getting out of a chair or bed, but this is becoming increasingly more difficult now, especially over the last few months. She's requiring a lot more assistance with personal hygiene, using the toilet, bathing, basically all of her activities of daily living. And since arriving at Wellbrook, she's become total assistance with all of her activities of daily living now. She can still ambulate. She can still walk around the hallways of the resident home area, but the staff are noticing that her gait is becoming more unsteady and she's becoming a higher risk of falls, although she has no history of falls prior to this. She also expresses that she's feeling lonely since moving into the home. Previously, her sons were visiting daily. Now that she's getting 24/7 care, those visitations have condensed a little bit, and they're coming almost once or twice a week only at this point now. She does share that she enjoys reading, singing, drawing, but she's not been active in any of the recreational activities here that we have to offer here at Wellbrook. So this is just a snapshot of I wouldn't say typical because there's many faces of dementia. Everybody has their own unique experiences, but this is one type of story that you may encounter in a resident that we care for in our RHAs upstairs. So I want to hear from you. What are some things that stand out for you in terms of this resident? How can we best support this resident? What are some of the care needs that you are seeing based off of this story that may suggest that they may need some additional support? What are some of the areas or symptoms or concerns that are coming out to you guys? Yes, definitely. And as we mentioned, like we have very comprehensive recreational programs here. She's expressed her interest. She just hasn't been engaged in any of those activities. So perhaps delving into kind of exploring, maybe it's a lack of awareness. Maybe she's not aware of these activities. Perhaps there's specific activities. We want to be also culturally appropriate and sensitive. She mentioned that her first language is Italian. Maybe there's some Italian cultured activities that we could try to get her to pull her in to get more involved with the residents. So very good. That's one. Yes, Sylvia, please. No, that's excellent. You can tell when you're talking to a nurse when you get responses like that. No, excellent. You want to engage, you want to take that interdisciplinary approach, and you want to highlight residents' strengths and work on them with the areas that need development. So if we're sensing that they're having more and more motor weakness, let's address that area. Let's get PT involved. Let's engage them in that physical activity. That's a very good suggestion. Sama, sorry, you had your hand up, or sorry, Diane, sorry. No, that's absolutely fantastic. I love the responses I'm hearing because it almost means my next slide is completely obsolete because it feels like I plagiarize you guys now at this point. No, that's excellent. We want to make this is their home. Our slogan over here is welcome home. We want all residents to feel welcome when they come into Wellbrook Place. So the resident was mentioning that their sons were visiting on a daily basis. You mentioned perhaps facilitating virtual visits to encourage that participation more. That's an excellent way to help a resident feel more familiar with the environment and integrate them into their current setting. Yep, Maria? Yes, no, excellent suggestions. All excellent suggestions. I think we have time for just one more, so I'll just go over there to the back. Judith? Yeah, and I love that. And that ties nicely into what Maria was just saying, but that sense of belonging over here, and then reorienting them to more familiar objects so they don't feel afraid, like, where am I today? Especially if they need that reorientation on a daily basis. So I'm just going to quickly, you guys have done an excellent job. Obviously this was prepared before talking to you guys, but just to highlight some of the key points of way we can sort of support residents. So first you want to start with that assessment. So what is that neurocognitive disease? Remember we talked about those 4 terms underneath the umbrella? This resident has a diagnosis of Alzheimer's disease from 2 years ago. What is the cognitive decline that they're experiencing? Well, they're having short-term memory loss, difficulty articulating their needs, and progressively increasing weakness and an unsteady gait that the staff are noticing. Progression. These symptoms have been worsening. 2 years ago, she was independent. Over the last year, she's become needs a lot more and more support and having a lot more assistance with their total activities of daily living. And then the functional impairment part. Now, because of that, this is what ties it all in. This is a resident living with dementia and some of the other symptoms that we have noticed that some of you guys captured over here, that loss of independence, the loneliness, and not being active in the recreational programs. So that informs the care plan then that we can use to support these residents. You guys touched on basically all of these from the non-pharmacological side, the timely assistance with ADLs, engaging the residents, giving them social opportunities to engage with other co-residents, providing culturally appropriate activities to help nurture that sense of belonging, and encouraging family visits. And as it was mentioned before, facilitating those virtual calls can help make them feel a little bit more settled in their environment. And then from a pharmacological lens, you want to assess obviously any of those medical symptoms, if they're having any pain, possible dementia medication, they were having some depressive-like symptoms. So trying to assess all of those things. And then ultimately, you want to make the appropriate referrals, the recreational programs, BSO, the medical team, as well as geriatrician for that holistic overview. So with that, I want to conclude with just these 7 key takeaway points. If there's nothing else that you guys remember here, outside of the fact that I like grapes and all the other things I can't even remember right now, but these are the 7 key takeaway points that I want you to remember about a broad topic of dementia. So first of all, it's a progressive neurodegenerative disease characterized by cognitive decline, and it's associated with functional impairment, typically presents with their activities of daily living. Number 2, there are several subtypes, umbrella term. The most common one that we will likely encounter and that is prevalent within our community is Alzheimer's disease. Number 3, there are 7 stages of dementia that residents progress. The middle to later stages, that's where we start seeing more of those responsive behavioral and psychological symptoms, although it can come earlier, but more prevalent in the middle to later stages of dementia. Again, those are those non-cognitive symptoms. They cause behavioral, mood, and personality changes. And then strategies that we can use to help residents that are living with dementia. Non-pharmacological approaches include the behavioral monitoring and having that interdisciplinary team approach to tailor the care needs specific to everyone's unique journey. And then pharmacologically, there's some medications that could slow the progression, not cure it, but slow the progression. And then in certain situations, temporarily alleviate those quickly escalating situations where residents are having behavioral responses. And then finally, engaging that, using that escalation support pathway to use your full scope of practice, but also pulling in other members of the interdisciplinary team to help utilize everyone's expertise to make this a team-based, person-centered approach to safely manage residents living with dementia. And with that said, that concludes this presentation. Thank you guys all for your time and participation. I know I did that whole spiel about time at the beginning, but if there are any questions, we'll open up. I think we have a few minutes. We can open up just for some questions that anybody have, anything specifically tailored towards the clinical case of dementia, and then I will pass it back to our Honorable Minister for some closing remarks. And if there's any questions in the chat, Alan, do you mind just highlighting it for us as well too? Anybody in the audience over here have any questions, any thoughts? Yes, please. Mhm. No, that's an excellent question. So we were highlighting some of that aspects when we were doing the case study as well. That using some of those virtual platforms, I think, is a great way to connect residents with their loved ones. And we have tablets in the resident home areas, helping them to engage in those phone calls. I know oftentimes when there's specific activities going on, staff have called family members to say, "Hey, I know this is something that you were engaging with the resident prior to them moving into Wellbrook Place. Is this something that you would like to share in that experience going forward?" That's another way that we try to bring them in as well too. So just kind of engaging a variety of those virtual platforms, whether visual, audio, and then ultimately trying to bring everybody together to best support that resident. So that's some of the ways that we've at least done it over here as well. Ashley. Uh, yes, please.
We do have a few plans in place, and one of the things that we're working on that is going to be taking a look at it is opening a dementia cafe, and the intent is to create a space where not only our residents and the caregivers can learn more and have the tools to be able to deal with some of these outcomes of experiencing dementia, but also create an opportunity for people living with dementia in the community that they can come here and have a place where they can connect with other people and have social connection, but also teach the family on gentle persuasion approach and how to manage those responsive behaviors at home. Because ultimately, the best bed in long-term care is your bed in your home, and that's how we want to do using the dementia cafe. Sorry.
Definitely, he's the expert on that, so he would be the best to answer that one. But thank you for that question. Yes, please. Sorry, my question is, so I'm going to defer. I see a hand over there. I'm going to just defer that to our DOC, Mira. Again, this is a collaborative team approach as well to answer some of these questions. Mira? Thank you, everyone. Thank you so much, everyone, for your participation today. Yeah, I think we have time for just maybe one more question. For sure.
And we are going to use the approach of train the trainer. So we are currently focusing on identifying some presectors and individuals in the home that can be our superstars that can support the rest of the team. We are also have completed the recruitment of our academic research and innovation team, and also the recruitment of an educator. And our goal is that we're going to start with huddles focusing on education and gentle persuasion approach. And our next next approach will be to open a simulation lab and a living classroom. So that will be the collaboration with the schools that are already in association with us, so that the students get the opportunity to develop the skill, but also on staff be able to develop themselves. And the investment on the simulation lab will create that opportunity to develop those skills. We also working with Baycrest. They have developed a virtual reality training where you can actually interact with a individual experience or responsive behaviors, and the AI system already embedded in the virtual reality will give you cues on how to properly approach and manage the care of those residents. So all those good things you will see coming to life, and Rama, Marie, and Colleen as our educator now will be leading all of this work of building the capacity of our team and increasing our competencies in this area.
Thank you, Ruben. And thank you, everybody, for those questions. If anybody has any other questions, just for the sake of time, feel free to just shoot me a quick email afterwards. I'd be happy to address any questions any of you got. But at this time, I just want to invite our Honorable Minister back to the podium just for some closing remarks.
Thank you so much, Raul, and thank you, Ruben, for sharing your insights as well. It's really awesome to hear my nursing colleagues share their expertise, skills. I'm so excited because just talking to Tess, she basically told me she has a proposal for everything. She has a solution for everything. I asked her, do you guys have a day program? No, but there's a proposal. Do you have a dementia cafe? No, but there's a proposal. How are we going to make sure that we don't transfer patients into the hospital unnecessarily? We're working on that. So, you know what? I'm so proud that we have Wellbrook Place to be such a leader and to be thinking out of the box and having a proposal for nearly every solution that I think is really, really important, including respite care, which I think, there's a huge need for caregiver respite especially in the region of Peel. And so I'm super excited and I'm looking forward to working with Tess and her entire team to get these proposals through. As you know, I'm the Minister of Long-Term Care, but we also have Minister of Health and Minister of Seniors and Accessibility. So we do have to work hand in hand across different ministries. And that makes it a little bit more complex sometimes to pass these proposals. But rest assured that I will be a champion in this space because dementia is something that's really near and dear to my heart, and I think that we as a government need to do better and work across silos. But let's do a quick little review about what we've learned today because that's the best way I retain information. And so feel free to just shout out the answer, okay? It's no pressure. If you don't know the answer, that's totally okay. No one's taking note, but let's just have a little bit of fun. And so how many people are living with dementia currently in Ontario? In Ontario. In Ontario. Okay, 316,000. Yes, excellent. And how about here at Wellbrook Place? What's the percentage of residents? 78. Perfect. And who can tell me the four things we need for a definition of dementia or Alzheimer's disease? There's four categories. Cognitive decline, yes. Progressive. What else? Neurodegenerative, yes. Ted, good job. And what's the fourth one? Very important one. Fourth one. No, you don't get to give us answers. No. Impairment in daily functioning. So yes, activities of daily living. Excellent, excellent. How about some non-pharmacological approaches? There are 6 that were listed in today's presentation, and that's really what we want to focus on as opposed to those pharmacological approaches as much as we can avoid using pharmacology. So what are the 6 that were discussed today? Go ahead. You guys know them. Social. Can you expand on that? Social, what does social mean? Excellent. Very good. What's another one? More nursing. Yeah, that's more nursing interventions. Absolutely. What's another one? Very Very good. So if the light is not bright enough, maybe their hearing aid is not put on properly. So absolutely, those environmental factors are very important. What else? Physical. So excellent. And we're missing two more. That falls under social. Environmental, we've discussed that, lighting, hearing, etc. Emotional, very, very important. So addressing those emotional needs. I'm sure you also have a spiritual chaplain. So those needs are very, very important. And the last one, very important, when we talk about person-centered care, what is what what is the last one? Sense of excellence, sense of self. And so I know we have initiatives like having items in the room to remind the person who they used to be, what they used to do. And we can see that working with our people living with dementia, that, if someone was an accountant and you come to them and you bring them a stack of sheets and a calculator, they lighten up. Or if there's someone was a ballet dancer, when they hear some of the music, they light up. And so we really see that sense of self, because that person is still there. So let's not forget that when we talk about person-centered dementia care, let's try to, as much as possible, engage that sense of self in our residents. So what's a big no-no in terms of pharmacological interventions? There was one that was mentioned. What's a big no-no? Very good. Wonderful. And in terms of the nursing scope of practice, what are some of there were three that were listed today that we can utilize? BSO, dose monitoring, excellent. Yes, so care plan interventions, go ahead. Absolutely. So that's a team approach, right? And so we're very lucky that we as nurses have, we're part of amazing teams, whether it's long-term care, but also in the hospitals, that we have these resources that we can tap into, like PT, OT, social worker. I know here you also have a mental health worker, which not all homes have. So you guys are very lucky and fortunate that you have access to other members of the team, so you can really draw on their expertise and together as a team develop a care plan. And so I just want to end on a little bit on a note to remind you to take care of yourself as well, because we as nurses, we always take care of others. We work 12-hour shifts. Sometimes we don't go to the bathroom. Sometimes we don't take a break to eat. But before we can take care of others, we have to take care of ourselves. And actually, studies show that caregivers of those living with dementia are themselves at a higher risk of developing dementia. So that's true for family caregivers, but I wonder whether that's also true for healthcare caregivers. And there are 12 risk modifiable factors that we can actually control when it comes to dementia, so that we live healthy lives and put our best foot forward to ensure that we don't end up with a dementia diagnosis. Can anyone name some of those risk modifiable factors when it comes to dementia? There's 12, so all of those: sleep, absolutely; rest, absolutely; stress, reducing the amount of stress. This is one of the things that we can reasonably do. Emotional. So diet and exercise, absolutely. But I'll give you two ones that I've learned that kind of shocked me. Do you know that hearing loss is one of the most common contributing factors to dementia? And I've been myself, I'm 35. I've been noticing a little bit of hearing loss myself. I'm in a conversation, I talk to a lot of people. Sometimes I can't fully understand. I'm definitely overdue for a hearing check. And because I'm so busy, I don't have time, I haven't done it yet. But studies show that when we look at a brain of a person who has hearing loss, and usually on average, people go 8 years before getting diagnosed with hearing loss, because there's also a stigma associated with hearing loss and wearing those devices. You can actually see the picture of the brain shrinking over time. So that's one of the things that we can do easily. Go get a hearing check, to improve your chances. Another one is vision. I'm also overdue for an eye check. And so I guess my message to you is, and make sure you take care of yourselves. It's really, really important that you do that so that you can take care of your residents, but also your loved ones at home, right? And so, thank you for everything that you do. Thank you for choosing long-term care. It takes a very special type of people to work in long-term care. It's not an easy job. The things that you're exposed to on an everyday basis, I know it's hard. I know it sometimes can be depressing. But there is light at the end of the tunnel. You know, working together with my colleagues, we're increasing the level of care. I'm very pleased to hear that we have 4 hours of care accomplished here per resident per day. That's absolutely phenomenal. And to the nursing students and other students with us here today, thank you for choosing healthcare. It's very, very important. And let me tell you, you're setting out on a very fun adventure. Within nursing, there are so many different things that you can do. You can change careers, you can work in long-term care, you can work in hospital, you can specialize. Sky is the limit. And that's why I chose nursing as a profession. Because I'm a type A personality, I don't like to be bored. And I knew that with nursing, it opens up a whole host of career opportunities for me. So you've chosen very well, and I wish you best of luck. Make sure you study hard. It's very important. You have to pass that NCLEX, but I'm sure you will with the support of your team here. And to all of you, to Tess, Ruben, Rahul, and everybody, thank you so much for having me. And I'm going to be a very frequent visitor in Walbrook Place. Thank you so much.